Hi, how are you?
Dr. Hassan is a gastroenterologist. Dr. Schwartz is with us today as well. We have Deanna right back.
Yep.
And you know what, I'll just let you explain what you do, what your role is a little bit, if you just,
So I'm Deanna Rapak. I'm one of the oncology dietitians. I work mainly down at the Cedar Crest campus, cover over at Hightown Oaks, Muhlenberg, even up here at Carbon. We assess our patients for nutritional risk while they're getting treatment, before treatment, after treatment. So we just kind of monitor them for any kind of like weight loss, changes in appetite, things like that. So.
this is Andrea Smith.
So my name is Andrea, I'm a genetic counselor. So I assist patients with genetic testing, helping to identify if their cancer or the cancer in their family might be hereditary.
And Noma.
Hi, my name is Norma Lazo, and I'm a physician assistant with hematology oncology. I work here with Dr. Fatamiko, who sends his regards, and basically we see all the cancer patients outpatient and give them their treatments and stuff.
And this is Dr. Joshua Nachmanson.
Hello, how are you? One of the general and colorectal surgeons with the Lehigh Valley Physician.
All right, so everybody's going to give a little presentation, tell you exactly some information about colon cancer, what you can do to prevent colon cancer, and what you should expect in the event you would have colon cancer. So we'll start with Dr. Hassan. And if you want to save questions till the end,
Do you have a
then
second?
we'll have a little discussion.
Yes, right at the end.
All right, so so colon cancer has been in the news because the recommendation was that everybody over the age of 50 should get screened. And then we found out that people who were 45, 44, 46 were getting cancer, and they were getting very aggressive cancer. So they changed the age limit. Now it's 45. If you know anybody who's 45 and has not had a colonoscopy, please advise them to do it. And why? Because this is the third most common cancer in the United States and all over the world, and it doesn't discriminate. I mean, you can have breast cancer, it's only mostly female, majority of them, believe me, males also get that. Then you have prostate cancer, but colon cancer is an equal level, affector and killer. But the other good thing about it is, if there is a good thing, that it can be prevented, okay? And it's like a tortoise, it grows slowly, so we can get a handle on it. So in the United States, it's the third most common cancer in both men and women. We don't know why younger people are getting it. So this is why the screening is important. And the reason is that usually the cancer grows in something known as a polyp, which is a little abnormal tissue in the mucosa. And if you do a colonoscopy and you remove that polyp, not all polyps are cancers, but most cancers come from polyps. So then you can prevent it right there. But if you don't get a screening done, then that polyp will become bigger and bigger, and then there'll be a change in it, and it will become cancer. So therefore, regular screening and removal of growth reduces the risk of developing up to 90%. That's a big number. And American College of Gastro screening by colonoscopy and polyp removal prevents before it can even start. And this is a colon. This person is facing you. It starts from here. A small ball enters into the cecum and then goes around like this. And then, that's your rectum. So usually these are the places where polyps form. And these are what polyps look like. It usually starts in a benign growth. You've heard of polyp, right? Oh, I had polyps, right? Well, those were the lucky guys because the polyps were taken. They'll never get cancer. But imagine the person who didn't get any screening and they had a polyp. Then if this was the polyp and we got it out, it will never go to this, right? Or here even. We can get them out. But if you don't, and if you come at a time when it has invaded the mucosa, which is the lining, under, see here, it's all intact, right? Here, it's broken. Then it's an adenocarcinoma, then it's cancer. And then we get Josh to take care of it and remove it. And then if, a lot of the times, it's not progressed much, and so that's all you'll need surgery. But in case that it has progressed, you will need chemotherapy and radiation where the oncologist and hematologist will come. But the good part about the colon cancer is that if you catch it in any of these steps, it will never progress to adenocarcinoma. And we used to think that it would take a polyp untouched 10 years to become cancer. So that's how some of the 50-year time and all these things came. These are some of the gross pictures of polyps. The simpler polyp, large polyp, believe me, they can be really big and different shapes. This is a pedunculated polyp. It has a peduncle. You can grab it and just cauterize it, drop. This is a flat. You have to remove it, and this is a, it will need more extensive work. And most of the polyps are harmless, but some of them can develop into cancer. And all cancers start as polyps. And the dangerous part is, even that big guy may not give you any symptoms. By the time it shows up, the cat is out of the bag, in other words. So that's why the screening thing, and the reason is that the colon that I showed you is this big, so it can accommodate a growth like this without causing problems. But then you will have, some people will have a change of bowel habits. Some people will have abdominal pain. Some people will have anemia that is unexplained. Some people will see blood in their stools, right? And some people will just have weight loss. And so those are symptoms, but we're talking about screening before any of this happens. So, of course, colonoscopy is preferred from our side because at least you can go in and while you're screening, and if you see a polyp, you remove it. And sometimes they're in folds, they are in crevices, so you have to be pretty careful to find them. Again, this is a polypectomy. This was the polyp. It was removed, and this is the area where it was removed. That's a tattoo that you see. Somebody tattooed it. See that? Blue. And so that in case we send it to the lab, if it comes back as cancer, when Josh goes in, he can see where it was because of the tattoo and just take it. So that's why this is done. So who's at risk for colon cancer? I told you it was an equal of, men and women. It gets them both. 1 in 23 lifetime and 1 in 25. And twice the risk for people born around 1990. Can you imagine this? I don't know why the younger people are getting it so much. And that's why we decreased the age to 45. And 4 times the risk compared to those born around 1950. Can you imagine it? Yeah. So this is why we're trying to reach out. And that's why I thank Chris and Lehigh Valley that they're trying to get, public education. These are the more important things to educate people. Okay, so some factors that increase the risk. If somebody in the family has colon cancer, parents, brothers, grandpa, grandma, right? Then you may have a gene and you're at a higher risk. If you personally, if they have a history of adenoma, means precancerous polyps. So think about it this way, somebody took the polyp out, it will never become cancer, right? People who smoke, obesity, gallbladder removal because of The bile salts, this has been shown, and physical inactivity, abdominal radiation if you have had before. Anybody who has had cancer of uterus or ovaries, even urinary bladder cancer, ulcerative colitis and Crohn's disease, but they cause cancer in a different way, not through pollen. It's just without a pollen. And African American race, so they are supposed to get it done every, or they were supposed to get it, the African Americans at 45 anyway, because somehow it's, they're more susceptible to it. What are the signs and symptoms? Most of them have none. That's why you do the screening. And when they have the symptoms, it's like something, you know, it's a little more advanced. You'll have blood in stool, like I mentioned, change of bowel habit, change in shape or size of the stool, rectal pain, weight loss, and anemia. So screening options are, you get a colonoscopy at the age of 45, and if you have any of those family histories, you get it every 5 years. You have personally more than 4 polyps or so, you get it every 3 years. And they can be detected and removed during a colonoscopy. Colonoscopy is mostly performed with, is the most performed GI procedure in the United States. And we also do tests which are called a FIT test, which checks for DNA. But if it's positive, you've got to have a colonoscopy anyway, because you have to find out what happened, why is it positive. And it's recommended every 10 years. Average risk means a guy has no problem, no family history, nothing. That's the average risk, 45 to 75. But if you have family history, then you have to talk to your doc and get it earlier. We usually do it every 5 years. Genetic testing may be required also if you have multiple polyps, polyposis, or there's something called Lynch syndrome. So they can do that too. And what are the myths? So it's like no excuses, get screened. Myth, I'm fine, because nothing is gonna, it's not gonna, till it's out, till it's more advanced, it's not gonna show you anything. Then myth 2 is, no one in my family had colon cancer. Yeah, well, you could be the first. And I have no risk factor. See that? Don't be first. Roughly 5 in 100 people get colon cancer if you're first. And then the other one, I have no risk factors. The single biggest risk factor is failure to be screened. And the myth 4, only men get colon cancer. That's equal, you know, it's gonna do the same. So one of the more important things, Dr. Schwartz will tell you about what is the instrument and how important colon cleansing is. Like if you don't, that's a 4.5 feet colon. If it's not cleaned well, the person doing the colonoscopy can't see. All right, so that's why we have to. Andy, you want to tell them what a scope is? We were hoping to get a scope, but it's blocked. And the importance of prep, and we have one rep who makes the prep also.
I mean, I don't make it personally, but.
So basically, the most important thing about screening for colon cancer is getting the colonoscopy. We have a lot of patients who go for Cologuard, and that's a very common screening test nowadays. And is it a good test? It is, because people go for it, and if they're positive, then they get colonoscopy. And it's very good at detecting colon cancer. It's not nearly as good as a colonoscopy in finding polyps. And, you know, to me, finding the polyps are really the idea, because you prevent problems before they occur. I think the Cologuard is a very good test in someone who refuses to have a colonoscopy, and if it's positive, then
They have to.
generally talk them into it. Or in someone who is relatively high risk, people who have breathing problems or significant heart problems, where you really may not want to put them through a colonoscopy unless you really feel it's necessary. So when a patient comes to the office, I explain that the colonoscopy, it's usually just one day off of work. The preparation starts the day before in most people. It's a clear liquid diet, pretty much the whole day. And then when they get home from work, then they take their first dose of the prep. And whether it's a tablet prep or a liquid prep, we always divide the prep into 2 days. So the first dosage is given roughly around 6 p.m. And we want people to actually not only take a clear liquid diet, but to drink a lot of clear liquids throughout the day. The more hydrated you are, the better the prep is. And so they'll take the first dose of the prep, and you can warn them that they're going to be on the toilet quite a bit throughout the night. The second dose, they actually take approximately 6 hours before the time that they arrive to the endoscopy center or the hospital, or if it's being done at the hospital. Most cases we do at an endoscopy center. The higher risk patients, patients with significant heart disease, pulmonary disease, brittle diabetics, people who have implantable defibrillators, all of those patients get done at the hospital as an outpatient. So approximately 6 hours beforehand, that will take the second dose, and that'll finish off the prep. It'll clean out something called chyme that accumulates in the colon throughout the evening. It's bile, and it's sort of a slimy substance, and it sort of interferes, and it's very sticky and hard to clean off during the procedure. So it's the second dose cleans that all out, so you don't have to worry about it. But when we're looking for polyps, we're looking for not only polyps that stick out, but very flat polyps. And some people develop polyps that sort of spread along the surface, and they're very subtle. And you really need a good prep to find it. And those are the type of people who can sometimes need colonoscopies much more frequently, even more frequently sometimes than every 3 years, because those polyps are big and harder to remove, and they can also show up much quicker. But in general, every 3 years is adequate for most people, even if they're developing significant polyps. So the second dose of the prep finishes the clean-out process. People come into the hospital or to the endo center, and they feel like they're cleaned out. In any patient who's having abdominal pain for any reason, I personally examine them before the procedure to sort of get a baseline to see what they feel like and if they're tender. Sometimes people come in with abdominal pain and they're not getting the colonoscopy for screening purposes. And it's very important to actually, you could feel a lot, you could do a much better exam once the colon is clean. Because sometimes when the patients are constipated or they have a lot of stool in the colon, you can't feel the abdomen quite as well.
Do you have a picture?
Yeah.
Show and tell, that's what.
So one of the preps we do like quite a bit, and people often prefer, rather than drinking a large amount of liquid, is something called the Sutab prep. And it's a total of 24 tablets. And people generally take them one at a time with lots of liquid. And it generally gives a very good prep.
You can drink water, you can drink clear juice, you can drink Gatorade. So, and the reason why Dr. Schwartz, emphasized on it, and I'm also telling that she's gonna show a picture also, is because you can miss the flat polyp that he's talking about. And then when you come back with something that's, hey, you did a colonoscopy, you didn't find it. Well, because you didn't give me the clear picture.
And one of the emphasis in the gastroenterology associations is that when we do a colonoscopy, we generally try to get to the end of the colon, or the beginning. From my standpoint, it's the end, it's called the cecum. We try to get there, as in a fairly rapid way. We don't look around. On the way back, I tell patients that we do the sightseeing. That's where we're really looking carefully for polyps behind each hole. And you take your time, and generally it takes at least 7 minutes, even without removing any polyps, to really carefully examine the whole colon.
See the gross pictures? That's why you need it clean.
And the beautiful thing about the procedure is people sleep right through it. The sedation that we use is called propofol, and it's generally used in almost all of the patients. And it works quickly. They go to sleep usually within 15 to 20 seconds. And then they wake up pretty quickly too, and they feel they can remember things. We used to use other sedation where they had a long period of amnesia. Most people remember things and they wake up nicely, like they're waking up from a nap. There's no nausea associated with it. In fact, this propofol has an anti-nausea effect innate to the medication. So most patients wake up and they feel fine and they feel like they can drive, but you have to warn them that they cannot drive that day. Because there may be some mild lingering effects.
Now you have the oncology people and that. But this is why you guys should be advocates and, spread it around that these are some
Questions?
Yeah, we'll do questions at the end,
Okay.
all right?
Okay, so like I said, I'm with the medical oncology group, and basically when a patient comes to us, most of the time, they already know that they have cancer. So now it's us trying to treat that cancer. So this is what you would expect, for the first few visits. The initial visit, you come in, you meet with the medical oncologist, and they review imaging, they review with you the stage of the disease that you're in. They'll talk to you about like the pathology from the biopsy. They'll talk to you based on that, then they'll come up with a treatment plan. And in that visit, once they've come up with a treatment plan, then you sign treatment consent forms. Second visit that we schedule for you is usually for educational purposes. There is a lot of information that's involved, like with the treatment, the visits that you have to do, the labs, the symptoms that you'll expect for whatever treatment you're getting. So at this visit, you meet with our oncology nurse and they give you what we call a teach. So they'll talk to you about like all these things, and then they'll also help plan all of your visits. They usually give you calendars with when you'll come for visits, how long it will take. They'll help you plan all the labs and when to come and so forth. Then following that teach visit, we then, now that you are informed and you have asked whatever questions you need to ask, we then schedule you for your first treatment visit. The things that are considered to choose treatment is the patient's history, like age, what other diseases do you have you ever had any cancer before? Have you ever had any chemotherapy before? What stage is the disease in? We also consider the genetic profile of the tumor. So the treatments that we give are set up in cycles. Could be a 2-week cycle, 3-week cycle, 4-week cycle, and so forth. So every time you come in, we tell you, okay, this is cycle 1. So a typical cycle on day 1 is when you're going to receive your treatment. But before you go down for treatment, you'll have a visit with either the oncologist or with the PA or NP that's in the office that day. So you visit with them. Basically, what happens at that visit is we see how you're feeling. Are you having any pain? Are you having any nausea? How is your blood work? Because before you come in, you'll have blood work. Is your immune system boosted enough for you to tolerate treatment? So we make sure that you're fit before you can go for the treatment. And if you're physically fit enough, then we go ahead and sign the treatment for you. And then you head down to infusion. Then a few days later, with colon cancer, most of our patients receive a drug that uses a pump. So when you go for your treatment, you'll get a pump connected to your body. That's going to dispense treatment over the next couple of days. So on day 3, typically you come in, and we call that the pump disconnect day. You come in, you don't have to visit with the oncologist or the PAs in the office. You go straight down to infusion, and they'll disconnect the pump for you. And then you're able to go home. Around day 7, between day 7 to 12, we have a visit that we call a NADA visit. That's when we expect you to be at your lowest point as far as the effects of the medication, as far as your immune system. That's when your immune system will be at its weakest point. So we like to see you at that visit for a follow-up, just to see how you're doing. If you are on chemotherapy, we'll review the labs at that visit so we can see where your immune system is. You don't have to receive any treatment. Basically, we just talk to you, see how you tolerated the treatment. Then if it's like an immunotherapy type treatment, you may not have labs, and we call that a toxicity check. And then towards the end of the cycle, let's say it's a 2-week cycle, around day 12, you'll have to go to a lab, get your blood drawn in preparation for the next cycle. During the cycle, we also have accommodation for sick visit. Sometimes you may get sick, you may just have a flu, for example, or you may get sick from the treatment. So there's accommodation for you to make that appointment. So the different types of treatments that we give for the colon cancer, the first one is chemotherapy. Everybody knows what chemotherapy is, but this is how it's broken down. We have what we call neoadjuvant chemotherapy. This is typically for rectal tumors that may be resectable. So you get this before you get any surgery to decrease the size of the tumor. And sometimes it's given with along with radiotherapy to also help decrease the size of the tumor. Then we also have adjuvant chemotherapy. So this is usually given after a tumor has been resected, and it's given for 3 to 6 months depending on the type of drug used. This helps decrease risk of recurrence if the goal was for curative purposes. I'll go to the next slide to explain the rest of it. So these are some of the drugs, or the typical drugs that we use. Most of our patients with colon cancer are on these drugs. So the first one, and one of the older ones, is you'll hear say 5-FU. It's fluorouracil. So most of our regimens are like 5-FU based. So those are some of the examples that we have. The name changes depending on what we have combined the 5-FU with. For example, that first one that says FOLFOX, it's 5-FU with oxaliplatin, another drug, and also with another drug called leucovorin, which is more of a supportive drug. If, like with the other one that says FOLFIRI, it's also 5-FU with oxaliplatin, another drug called irinotecan, and the leucovorin. Those first two regimens are just IV medications. Then there's another combination that uses an oral form of the 5-FU, and that's the one that's written as Capiox. So you'll get an oral form that you'll take. You may take it 1 week on, 1 week off. Sometimes we'll say take it 2 weeks on, 2 weeks off, and then you'll come in for the infusions for the oxaliplatin. We also have targeted therapies. So these are drugs that target specific receptors or proteins. These are mostly, I think, monoclonal antibodies, so they'll end with MAB. A common one that we use is called bevacizumab. All the names for cancer treatments are very long and hard to say, but it's also called Avastin. That's the common name for it. So this one binds to blood vessel growth factors to help starve the cancer from growing. Another example is another drug called panitumumab. That one targets receptor cells and prevents the tumor from growing. Another type of cell that can be targeted is the HER2 positive. So if we have cancer cells that are HER2 positive, I'm sure most of us have had that reference when it comes to breast cancers. So we have a drug, we have certain types of colorectal cancers that are HER2 positive. And based on that characteristic, we use a drug called trastuzumab. I don't expect any of us to remember the drugs, but it's just to explain that we have different types of drugs. So these are different from chemotherapy in the way they work and also in the side effects. We also have immunotherapy drugs. So the immunotherapy drugs, they work on your own, they harness your own immune system to kill the cancer cells. So examples of those immunotherapy drugs, common ones that we use is one called Keytruda, and we also have one called Opdivo. So these work on your immune system so your immune system can kill the cancer. Typical side effects of the immunotherapy drugs is inflammation of anything in your body from head to toe. For example, if you have inflammation in your digestive system, you may just have a lot of watery diarrhea. Or if it's in your lungs, you'll have like chest tightness, cough and stuff. So when you come for those pre-treatment visits, if you're on this particular group of drugs, these are some of the questions we'll ask you. Are you having diarrhea? What type of diarrhea are you having? Are you having chest tightness? And if it seems like you're having an immuno-based reaction, then we'll hold the treatment for a while and put you on some steroids to help you recover from that. For the infusion medications, patients typically have a port placed. It's usually on your chest or left side or right side, it doesn't matter. But that port is placed prior to you beginning the treatment. And it's placed by the radiologist or interventional radiologist. And once you have that port, you can keep it for the duration of the treatment. It could be on there for years. So it can be accessed whenever you come in, either for treatment or fluids and so forth. To assess treatment response, we follow a tumor marker called CEA. That's the tumor marker for colon cancer. So this is not like diagnostic, and also it may not, tell us whether you're getting cured or not, but we use it along scans that we do on a regular basis. So when you first start the treatment, you'll get scans every 3 to 6 months. Then as time progresses, we space the scans further apart. And then for chemotherapy, these are the typical symptoms that you may experience, like nausea, vomiting, diarrhea, constipation, and of course you may have pain depending on where the tumors are. Also because you're going through a lot, you may need some help, like with mental health issues like depression and so forth. So we do have recommendations for whatever you're going through, and to try to help you support, to try to help give you support. So like for example, with nausea and vomiting, we'll prescribe some drugs for you to help curb that. For diarrhea, we'll give you Imodium, constipation, laxatives, and so forth. Pain, we have over-the-counter options. We also have very strong medications to help you cope. We refer to mental health services and a social worker to work with you. And these are the different centers we have here in the Lehigh Valley, about 2, 4, 6, 8 different places where you can have your medical oncologist needs met. And that's it.
Which is the new experimental treatment which you're doing with slum cataract?
I am not sure which one you're referring to. Yeah, I can find it.
Nice to see everyone. Thank you all for coming. My name is Josh Dawkins. I'd like to thank Christine for asking me to speak today. I'll talk about the surgical component of this disease, and as Dr. Hassan so expertly said, it's the third most common cancer in this country, but it's actually the second most common when we factor in deaths from all cancers. So it's a big problem. That's why every March we like to highlight its importance. And prevention is really the best way to treat this, because if you can prevent it from forming, you don't have to come and see me and get a big surgery. But assuming, unfortunately, you get diagnosed with this, and in fact, in my office today, I had a 43-year-old lady with no family history, did everything right. She's not 45 yet, so no reason to get screened, and so she's one of these people, unfortunately, that fell through the cracks and has a cancer diagnosis and is going to need surgery. So, yeah, prevention is...
one more.
Sorry about that.
You're fine.
I'm not very
So
fast.
double click, huh?
Yeah. All right. So this was kind of alluded to, but there's different phases of a cancer development. Very early stage, you form a polyp, and then over time it gradually gets larger, and as it gets larger, it can become more invasive and start growing into the wall of the colon. So the first two cases here where you have a polyp, which there's no cancer yet, or an early stage cancer, many times these can be removed endoscopically and don't require any kind of surgical procedure. When it's starting to grow into the wall of the colon or spreading into adjacent lymph nodes, then that's where a surgical resection is required. And then on the last schematic there, that's a metastatic cancer where it's spread to other parts of the body. So the role of surgery in this type of cancer is usually limited and more palliative. So if someone's having issues with bleeding or obstruction, then sometimes there's surgical procedures, but they're not done to cure the disease or to prolong survival. So if someone gets a colonoscopy, they find either a large polyp that maybe was not suspected to have cancer in it, and upon final pathologic diagnosis, you come back with a tumor in it, or you find a clear-cut clinical cancer. Then what's the next step? Well, the next step is you want to learn about it. You want to know, has it spread anywhere else in the body? So usually the first test that's ordered is an imaging test to look throughout the body, almost from head to toe. Because colon cancers in particular, if they do spread, will typically spread first to the liver and then sometimes to other parts of the body. So that's really important. And you can see this is a scan here. We have all these spots throughout the liver, so that unfortunately is a widely metastatic cancer. There's also some blood tests that get done to look for tumor markers. For prostate cancer, there's a particular tumor marker called the PSA level. And in colon cancer, we use one, it's called CEA. It's not a perfect correlate, but it's a commonly used tumor marker. Sometimes, most of the time, if there's a suspicious polyp that's removed or a mass that's seen in the colon, the endoscopist will put a tattoo marking, as you saw from the inside. You can see here on the outside, it's a little subtle here, but this is the tattoo. You can see sometimes looking at the outside of the colon, it's not obvious where the problem is. So these tattoos can be very useful to the surgeon to kind of better delineate where the disease is present. In very rare cases, there was a polyp that wasn't suspected to have cancer in it, so there was no obvious reason at the time to tattoo it. Very rarely we'll have to go back endoscopically to go back, find the polypectomy site and tattoo it so we can identify it during surgery. Almost the number one question I get asked at the first visit is, does this mean I'm going to have to get a colostomy bag? So the good news is almost always it does not mean that. And to the extent sometimes people do require a colostomy bag, it's usually temporary. Only in circumstances where the tumor is very low down in the rectum that has not responded well to what we call neoadjuvant treatment with chemotherapy and radiation, those are situations where a permanent colostomy would be necessary. But I used to say to people, colostomy, as bad as it sounds, you can do anything you want in life with a colostomy, maybe short of being a swimsuit model or something like that. But then I found out they actually do have swimsuit calendars, so I can't even use that anymore. And then, nowadays the field where people are better trained and we're doing much more minimally invasive surgery. So many times with a colon cancer surgery, you don't have to get a big scar or a big incision. Rarely people come in with 10, 20 previous operations, their belly looks like a road map. Okay, well that person probably is going to need a big open operation. But the vast majority of the time we can operate with smaller incisions, often using either a laparoscopic technique or a robotic surgical technique to minimize the number of incisions or the length of the incisions and expedite the surgical recovery. So, location in the colon is somewhat important for the surgeon. Obviously, we have to know where this is. It matters for technical aspects. And as the schematic shows, there's a right side, a middle or transverse colon, and then a left side. So it breaks down like this. About a quarter of the lesions are found on the right side. And then on the left side, about half of the lesions when you incorporate the rectum and the sigmoid colon. So that's where the majority of these lesions happen to be. And each segment of the colon has a particular anatomic blood distribution, blood vessel distribution. And that's important to know because also along these blood vessels are where the lymph node drainage system lies. So when you do a surgical resection, not only do you remove the intestines, but you also remove the blood vessels and the surrounding lymph nodes associated with it, because that's going to determine possible need for additional treatment and prognosis depending on whether or not the tumor has spread to any of the lymph nodes. So this schematic just shows several different options. So if the tumor is here on the right side, you remove this section of the right colon, its surrounding blood vessels and lymph nodes, and then you reattach the small intestine to the colon there, and that's kind of the end result. So now the latest and greatest and modern marvel of technology is robotic surgery. So this has really made the dissection, especially for tumors located down in the pelvis, in the rectal area, much easier to do, and with much less tissue trauma, which means less pain, faster recovery. So the robot has been a game changer for especially tumors on the left side of the colon and in the rectum, but we use it for tumors throughout the colon. And everyone always asks, well, is it the robot doing the surgery? Maybe in the future now with these artificial intelligence systems, they'll develop the software to do that. But there's actually a console that sits on the side of the room, and the robot is docked to the patient. This is the second generation model of the Da Vinci robot, which is made by a company, Intuitive. There's some other systems available as well. And the robot is really nice because with traditional laparoscopic surgery, you're just looking at a screen which is in 2 dimensions. You're using basically instruments that don't have any degrees of movement to them at their tips. So they're basically large sticks that you have to manipulate at the wrist level. So it amplifies any kind of tremor that you have. Its precision isn't always as good as what you get with the robot, but it's wide. Laparoscopic surgeries are widely available, so any place in the country has done laparoscopic surgeries probably since the 1990s. There's very little extra training that needs to be done for staff and ancillary support. The robot, obviously, it's more expensive. I mean, these run upwards of $1 million, and then there's additional training that requires to get a team that knows how to take care of it, how to operate it well. But it gives you a 3-dimensional view of the operative field, so it's really nice. I mean, you feel like you're in the body doing the dissection, and it's a much, it's slicker, I would say, dissection. Plus, it's more enjoyable for the surgeon too. It's like if you like video games and things like that. But it gives you up to 7 degrees of freedom, so you have the ends of the robot, can wiggle just like a normal wrist would. The downside is it doesn't give you the same tactile feedback that you get with a laparoscopic procedure, because if you rub up against something, you're gonna feel that in your arm. You don't get the same feedback in the robot. But over time, you adjust to that and you adapt to it. And the visualization that you get far, takes that limitation out of the equation. So I figured I'd try to find a video that maybe gives you a sense for the precision and the dexterity of the robot. So here's.
That's surgery in the brain.
Yeah. Very, very precise, no tremors, and it's a lot of fun. These are a lot of, surgery residents. You do a lot of these little training techniques on different, fruit products and vegetable products and things like that. But it really is a modern marvel. And where in the past someone would maybe have to be in the hospital for up to 7 days with a traditional open colon resection, now with robotic surgery, many times you're out of the hospital in 2 to 3 days. And within a few weeks, you're kind of back to your baseline, functional status. So it's now that it's been in use for over 10, close to 15 years, it's no longer a novelty, but many people benefit from getting this type of minimally invasive procedure. So I guess I can answer some questions at the end of the talk. Thank you.
So the good news is that you can avoid all that chemotherapy, this, that, if you just have sleep.
And also nutrition does play an important role as well in preventing colon cancer. So in addition to genetics and screenings and everything like that, diet and lifestyle does play a large role in preventing colon cancer and any type of cancer as well. So it is estimated that about 40% of cancers, including colon cancers, can be prevented through diet and lifestyle habit changes. So that's going to include your diet, obviously, drinking, so alcohol intake, any kind of smoking, physical activity as well. So incorporating all these different changes can prevent our risk of colon cancer. So there are some things that increase our risk of colon cancer specifically. So one of those is going to be processed meats. So that's going to be any of our lovely meats that you see right here. So our bacon, even our deli turkeys, hams, any of those good charcuterie board meats, so your prosciutto, your pepperonis, things like that, are all cured with what we call nitrates. And those nitrates that are used in the curing process can actually basically damage the lining of our GI tract, which can let cancer basically grow. Red meats as well are recommended to limit in our diet. So we recommend about 18 ounces a week of red meats if we want to have it in our diet, but limit it as much as possible. That's going to be based upon the fact that the red meats have heme iron, or heme in it, and that can attack our GI tract as well. Alcohol intakes, obviously we want to keep it limited as much as possible. So about 2 drinks, it starts to increase if we start drinking more than that. Obesity and inactivity also can cause increased risk of colon cancer. So if we're cutting out our red meats and our processed meats, what other kind of protein sources are there? There's a ton. So we're going to be able to get protein sources from all these lovely sources that you see up here, including our green vegetables. So any kind of nuts, beans, legumes, even our nut butters, peanut butters, almond butters are all great sources and plant sources of protein. If you want, you can always keep lean sources of protein in our diet, so that's going to be our fishes, any kind of salmon, tuna, tilapia, things like that, also chicken, turkey, just not the processed kind in the lunch meat form. You can also incorporate dairy products into your diet, so that's going to be yogurts, cheeses, milks. Low-fat options are always preferred, but whole fats are okay as well in moderation. Eggs, they get such a bad rep, but they are a great source of protein, so you can incorporate those into your diet as well. Like I said, some vegetables have protein in it, and then also some grains have it in it. So like quinoa, I'm sure is one everybody knows about. That is a higher source of protein, but also a good whole grain to incorporate in our diet. So decreases our risk of colon cancer. There's a lot of different things out there. Like I talked about, it's going to be your lifestyle and diet changes. So incorporating fresh fruits, vegetables, even frozen and canned are okay. And whole grains into our diet. We do recommend for fruits and vegetables, we want to try to get at least 5 servings of fruits and vegetables a day. So whether that's going to be fruits in the form of like frozen fruits or vegetables in our omelet in the morning, anything like that will count as a vegetable. Whole grains, we do recommend making half of our grains for the day whole grains. So you can incorporate that by maybe having brown rice instead of white rice. Oatmeal in the morning for breakfast would be a great source of a whole grain to help decrease our risk of colon cancer. Dairy products have also been shown to decrease risk of colon cancer, so that goes back to incorporating our good sources of protein. So our milks, our cheeses, our yogurts and cottage cheese and things like that would be good to incorporate. Physical activity, they do recommend about 150 minutes a week of physical activity. So that can be going to the gym, going for a walk, just staying active, not sitting and being more sedentary during the day. That can decrease our risk as well. And then there's calcium supplements and vitamin D supplements. There is some evidence out there showing that this can decrease our risk of colon cancer. But obviously always check with your doctor before starting anything. We want to make sure it's going to be a best fit for you before we start anything that we shouldn't be. And then of course we talked about how to increase our fiber. So we want to make sure we get good sources of fiber in our diet. So that's going to be including any kind of nuts, beans, legumes. So any kind of like black beans, if we have a chili, that would be great to incorporate. Lentils, if we do like a lentil soup of any kind. Fruits and vegetables, obviously, a great source of protein, very colorful. Eating from the rainbow is what we recommend. And then our whole grains, so you see down there that oatmeal also includes some berries in there as well. So you get double a dose of fiber right there. And you see they also have nuts you can put on top, so even more fiber to include. You can also do the quinoa like I talked about, any kind of whole wheat bread. If you like snacks, a great whole grain snack is actually going to be popcorn. So that's a good snack to incorporate as well. Obviously, we don't want it drenched in butter. So as simple as possible is recommended, but also a great source of whole grains. And then nuts as well. That's going to have great sources of fiber, great sources of healthy fats, so your omega-3s are going to be all found in those nuts. Just watch the portion size of those because it's very easy to overdo it on them. But they're good. All right. Kept it simple.
Right, I'm gonna wrap stuff up. Alright, so as a genetic counselor, my role often with someone's cancer journey, whether it's for colon cancer or other cancers, is to help answer some of these questions. Is my cancer genetic? My family member had colon cancer. Does that mean I'm gonna get it too? Or am I at high risk of colon cancer? These are all questions that we can help sometimes answer by looking at the family history and considering genetic testing. So we know about 5% or so of cancers, particularly colon cancers, are hereditary or genetic, meaning they can be linked with one single gene that runs through the family that can cause much higher risk of cancer. So I have a couple listed here. So there's Lynch syndrome, which is the most common cause of hereditary colon cancer. We have some polyposis syndromes, FAP and MAP, where people get many polyps. There's juvenile polyposis, Busch-Jaeger syndrome. There are many genes that we can see associated with colon cancer. And all of these genes can often cause risks of other cancers as well. So someone might come in because of their family history of colon cancer. If we find one of these syndromes, it might say we need to be looking for other things too. So why is it important to know whether or not a cancer is hereditary? Well, sometimes it can help influence treatment. So if someone's going to have a surgery, maybe we need to know if they have a high risk of getting another colon cancer. We might do a larger surgery. So instead of removing a small portion of the colon, maybe removing a large portion or even the entire colon. Targeted treatments. So that Keytruda that came up, that can be particularly helpful for people with Lynch syndrome. When to start screening and how often to do screening. So people who have a higher risk of colon cancer, we might start earlier. We might start, say, even in the 20s, and we might do colonoscopies as much as every 1 to 2 years for people who have these hereditary syndromes. Prevention, sometimes we can consider medication. So if we know someone's at high risk, sometimes we might even recommend a daily aspirin to help those polyps from forming. Or we might even do preventative surgeries in some cases. So those situations where people get sometimes hundreds to thousands of polyps, it could only be a matter of time until one of those becomes cancer. So we might go as far as removing the entire colon for prevention. And it can help us understand risk for family members as well. So I have a lot of patients who come in and say, well, I've gone through this. I want to know about my kids. Are they going to have to go through this? Are my brothers and sisters going to have to face colon cancer? So it can help us better understand risk for family members. So when I meet with a patient, the first thing we do is we go through the family history. I make a little chart that's called a pedigree. But to really understand the family history, we need a lot of information. So I typically ask people to find information about their family members. So first, second, and third degree family members. So first degree relatives are like your parents, your siblings, your children. Second degree relatives are our grandparents and aunts and uncles. Third degree relatives are first cousins, great grandparents. So we want to know if these people have had cancer, what type of cancer they had, how old were they when they were diagnosed, how old they are now or how old they were when they died. Did they maybe have an occupation or a hobby, something that put them at higher risk of cancer? Sometimes certain ethnic backgrounds or people from certain countries of origin may have higher risks of having a hereditary condition. And if someone has passed, what was their cause of death? So then, we go through all this information, and some people are like, that's a lot of information. How do I find all of that out? Well, talk to your family members. Talk to your parents. Call up your aunts and uncles. Whether it's a family reunion, maybe over holidays. Thanksgiving happens to be National Family History Day, so great day where a lot of people get together and you can talk to your family members, and it might seem kind of funny, but bring up the, hey, did you get your colonoscopy this year? How did it turn out? Do you have any colon polyps? Might be good, a little bit of information to get. Other sources of information, family genealogy. Does anyone do like Ancestry.com, that kind of thing? That can be some way to find out some information. Things like family Bibles, baby books. These are often places where people will jot down information about the family. Death certificates. If someone has had cancer, it's noted on their death certificate, even if it's not what they died of. So that can be a good way to find some information. And medical records. Oftentimes we recommend if someone's diagnosed with cancer, Keep your medical records as you go, and that can be certainly good information for your family members to know. I listed a couple little online tools there. There's the Surgeon General's My Family Health Portrait, the Genetic Alliance Family Health History Tool. These are websites where you can go online and it'll help walk you through these questions about your family and give you a place to kind of aggregate that all. If someone comes to see me in the genetics department, oftentimes we'll send them a link to a piece of software we call Progeny, where it'll ask all these questions, and that gives us that information prior to the appointment. And then once you go through getting all this information, make sure you keep a hold of it, keep a copy, maybe share it with your family members so they have that information as well. So one of the first clues that we're going to look at is age. How old was someone when they developed cancer? So oftentimes we think of cancer as being something that happens in older individuals. When we see it in younger individuals, that can be more concerning. So with colon cancer, seeing a colon cancer diagnosed under the age of 50 is considered to be concerning of increased risk. This little picture here, this is the pedigree. That's a little family history we often draw. So women are circle, men's are squares. These two people were married, these are their kids. So we have a woman diagnosed with colon cancer at 43. Then we're going to ask about those family history. So again, have other people in the family had cancer? Have other people in the family had colon polyps? If they had cancer, what type of cancer, how old they were? So putting it in this picture helps me see how is this running through the family. If we're seeing many people across many generations, that can be indicative of what we call dominant inheritance. If it tends to go across siblings, that's recessive inheritance. And that helps clue me into what gene might be in play. Family history of other cancers. So seeing colon cancer with uterine cancer, maybe stomach, ovarian, that looks very much like Lynch syndrome. There's a syndrome where we can see colon cancer and breast cancer. It's caused by a gene called CHEK2. We might see, again, those people with many, many polyps. That can be our polyposis syndrome, FAP and MAP. So this is a kind of a Lynch syndrome looking family. Again, people with polyps. We're looking for those lots of polyps. So here you can see tons of polyps. Oftentimes we say this is a carpeting of polyps. Someone like that probably has familial adenomatous polyposis syndrome or MUTYH associated polyposis, so MAP syndrome. So if someone has more than 10 polyps, particularly those adenomas, those ones that can become cancer, that's when we become concerned that they might have one of those polyposis syndromes. Or if we see a more rare type of polyp called a hamartomatous polyp. If your doctor sees that on your pathology report after a colonoscopy, they're probably going to tell you to come see me because we can see that with a syndrome called juvenile polyposis or Peutz-Jeghers. Sometimes other medical conditions, things that might not even seem like they're associated with cancer. So we can see sebaceous gland tumors, so little tumors basically of the, kind of like the sweat glands. Sometimes they're sebaceous adenomas, sebaceous carcinomas, which is almost like a type of skin cancer. These can be associated with Lynch syndrome. Chirpy, that really long word there, is congenital hypertrophy of the retinal pigment epithelium. This is something your eye doctor might see. It doesn't affect your vision, doesn't cause any issue, just basically seeing like little freckles kind of on the eye. That could be a syndrome or a symptom of FAP, one of those polyposis syndromes. Same with desmoid tumors, a type of benign tumor, but can be associated with FAP. Or there's a condition called hereditary hemorrhagic telangiectasia. These are people who get little, there are kind of misconnections between the veins and arteries. Can often cause a lot of nosebleeds and little kind of red, like broken blood vessels on the face. But the gene that causes that can also sometimes cause juvenile polyposis syndrome. So a couple other things we might look for and might not really say, just kind of say, oh, you know, yeah, this is associated with colon cancer, but it can be. Sometimes if someone's diagnosed with cancer, we'll do some tests on the tumor itself that might help tell us if it's more likely to be associated with a syndrome called Lynch syndrome. So we do this microsatellite instability testing called MSI. This looks for little breaks in the DNA. The Lynch syndrome genes are our mismatch repair genes, or our spell checkers of our genome. So if someone has a gene mutation, a change in that gene that causes it not to work properly, that might cause these little breaks in the DNA. So we test for that using microsatellite instability. Oftentimes, an oncologist will look for this MSI because it helps determine treatment as well. And then there's this IHC, immunohistochemistry, that's what we're seeing over here, where basically we look to see if the protein that these genes make are in the tumor. We use a dye. So you see here, this MSH6 and MSH2, see these dark spots? That means those proteins are there. MLH1 and MSH2 are missing. That means one of those genes isn't working properly, and it could be because of Lynch syndrome. So if someone comes to see me, we go through the family history and their personal history, and it looks kind of suspicious, like, yeah, maybe this could be something hereditary, we're going to recommend genetic testing. So genetic testing is a blood test, and what it looks for are gene mutations, changes in the genes that cause them not to work properly. And it's these mutations that get passed down through the family. So we can see if someone has a mutation, and if testing comes back positive, then we would basically give someone a diagnosis of, say, Lynch syndrome or another hereditary condition. Oftentimes on this genetic testing, we're going to look at many, many genes. So generally with colon cancer, we're looking around about 20 or so genes minimum. Sometimes based on family history, we might look for other cancer-related genes as well. But it's important to know that genetic testing is just one part of the overall puzzle. So there's a lot of things that doctors look at when planning treatment, planning surgeries, planning screening. Also, just if someone, say, has testing test negative, doesn't mean they're never going to get cancer. This just tells us whether or not someone might be at high risk. And there's a lot of things involved with genetic testing. So some people decide it's something they don't really want to know, that this information might just make them nervous, just be something to worry about. There are some people are concerned with how it might, say, affect their life insurance, things like that. Those are all things that a genetic counselor will talk about to help determine if genetic testing is something you want to move forward with. And some people kind of come to me and say, well, why do I have to come see you in this genetic testing that's going to make me take some time out of my day? They bill my insurance thousands of dollars, but most people don't pay that. When I can just go order a box online and do it myself. These aren't going to tell you about hereditary cancer. At least it's going to be very, very, very minimal. I know 23andMe, one of the more common one, it looks at one gene associated with colon cancer. It's called MUTYH, but they're only looking for 2 mutations that are particularly common. There can be hundreds of different mutations in MUTYH, so it's very, very limited. It's not really going to tell us about cancer risks. So if you're interested in these tests, just to know what your ethnic background is, if you have certain traits, so I know 23andMe will tell you what type of earwax you have, or if you have a widow's peak, something like that. But don't use it to make medical decisions. So, but it's certainly something that I can always answer some questions about, but generally the type of testing that I do is much, much different. That's all I have, so I think we're going to turn over for questions.
That was a lot to digest. You guys came here just to see how screening works, right? Well, this is a plug for screening, that to avoid all that problem. So you have to tell younger people in your family, somebody, like you just said, he saw a 43-year-old today, and so you have to tell them that, listen, it's 45 now, at least get checked around that time. And then if you are found with cancer, then there is oncology that can take care of it, there is surgery that can take care of it, there is nutrition, there is genetic people who can actually find out that it's not only you, but the whole family is in danger, right? So that's why the whole package is important.
And don't ignore symptoms just because of age. I've had several patients in their 20s with colon cancer over my career, so it's...
The youngest I saw was 17. Who had rectal bleeding but didn't come because he thought he was embarrassed that it was hemorrhoids. Doctor thought it was hemorrhoids. And it was metastatic.
And
So-
Doctor, you meant it said up to age 75. But-
I didn't say that.
Oh, well.
The government, the recommendation says that.
Okay,
But-
because if you have somebody with a history, like my husband has a history of polyps and colon cancer in his family, and you spoke to him, so he's 76, but he's still going to get,
If he has, yeah, you know, these are just guidelines.
okay.
We look at the whole person. If your husband didn't have any family history or
Yeah,
personal
yeah,
history,
yeah.
I would probably not worry about it. But because he has it, we keep an eye on it, that kind of thing.
And is there an age where, I think there's a perception
Well, there is a reason,
that they say 80 and above, that nobody does
Actually, age
anything anymore for?
85 is considered the
Oh,
upper
85.
limit.
right,
Oh,
right.
so it's okay.
I thought it was 80.
No, it's
I'm
actually,
81. I had my last one, they said, that's it, you won't need any more.
well, if it was all clear, then I would agree with that. But I'll tell you, I had one instance where a patient who kept having polyps, then he came to my office and he was 86, a very healthy 86-year-old. And we decided, you know, he's old enough that we were gonna stop. Well, unfortunately, 5 years later, at age 91, he had a colon cancer and required surgery. So, you know, that one case sticks in my mind, and yet, you know, some 81-year-olds are way healthier than some 61-year-olds. So I think you take everything into
Yeah.
account.
But
And
the
and
rule-
if they've,
The rule of thumb is that if you had a clean colonoscopy and now you're 81 years old, there's no need for.
Right, right. And the reason is that the risk of anesthesia and other things may supersede, and they also go by a 5-year survival rate. Like they guess in their head, well, you may die before that.
5 years.
Yeah, that kind of, but his guy was 91.
yeah.
Yeah.
And the risk of the prep itself is, you know, people get dizzy with all the diarrhea, they can fall and hit their head or break their head, or, you know, just putting someone older through a prep is,
But it's not unusual to find polyps in a lot of people, correct?
Correct.
yeah, and if they keep having polyps at age 80 or 82, you know, then you may consider going up to a little higher.
Yeah, because if they keep on making them,
Yeah. And what causes a polyp?
oh, that's a good question.
Well, that takes an hour to
It
answer.
has a lot to do with
Who's
with
gonna take
diet
that?
and,
Lifestyle.
Just like she mentioned,
yeah,
your diet also,
yeah.
and like the red meats and all the other things, smoking, obesity, you know. And I think there is a whole interest in why we're seeing younger people. Is it because of the processed food they're eating? Is it because of, we used to drink from the tap, and now it's all plastic bottles, is it seeping? Nobody knows yet, but I'm sure people will start researching on it, because suddenly there's 40, 45, I've seen it. I mean, he saw 43, I saw 45, and he's seen, I mean, the youngest
20s.
70s, you know, 17-year-old, so this is why we'll have to, like, if you don't have a genetic background, so then you wonder, is it the diet, is it the diet and the environment, what is it? So,
And if you look at certain countries, you know, in the Far East, they don't have that much colon cancer. In Africa, they don't. They have other types of cancers and problems, but it is sort of more a disease of westernized countries, you know, Western Europe and United
I
States.
know these plastic bottles, they tell you, you know, the water's in them now, once it's empty, you shouldn't just refill your plastic bottle.
Yeah.
You should throw it away.
yeah. See, I don't have one.
I'm
Dehydrating.
I'll open the spigot. All right, so any other?
Well,
Do you
Yeah,
have
go
the Da Vinci equipment here?
Not yet. It's,
in Allen.
On his wish list,
Oh, no.
But he-
for this facility, but in the network.
But he can
almost
take
every
you.
other
Oh,
place
you're
is,
gonna-
yeah.
he can take anybody anywhere.
Right.
But
You currently take your patients to see?
Well, I'm mainly out of Hazelton,
Oh.
but yeah. But, you know, eventually the plan for here is to get a robot at this facility.
They have one at Hazel?
my mother had colon cancer. She was discovered when she was in her 60s, and she changed her lifestyle and her diet. She lived to be 91. I think that it sort of came back when she was older, but she was very conscientious about her screenings. My sister has also had colon cancer and had part of her colon removed. My other sister and I had started screenings when we were in our 50s and go religiously. I'm on a 3-year plan right now. I also had some genetic testing done down at Lehigh Valley where I just spit into a tube, and I think it was a company called Invitae. And they told me that I didn't have necessarily any markers for colon cancer, but I'm concerned about my son, who's 33. He's heavy set. He drinks a lot of water out of plastic bags. He likes red meat, and is constipated frequently. And I'm just wondering, should maybe he start at 35 because of the?
You know what, I'll tell you what, constipation can probably, if it doesn't get better, then it's a change of bowel habit. He could get a colonoscopy without screening.
So would you suggest that he starts earlier than 45?
Well, you have like a lot of family members,
Well, my sister's in Japan. She just had her colonoscopy and they found polyps. They actually kept her in the hospital several
Usually,
days.
the rule was 10 years before the first degree relative. So who was the youngest first degree relative?
Well, probably my sister. She was probably in her 50s.
Yeah, so as a rule, it would be like 40, but all bets are off now.
Because I'm concerned about him.
Yeah. So symptoms don't follow. If you're symptomatic, it doesn't follow age. You see a drop of blood, you have rectal bleeding, you have change of bowel habits, you have belly pain, you have weight loss unexplained, you have anemia, you're going to get a checkup.
There are so many patients who come in with rectal bleeding, and it turns out the rectal bleeding is due to hemorrhoids.
Yeah.
Yet, when we do the colonoscopy,
We find something,
large
yeah.
polyps high up in the colon
Yeah.
that had nothing to do with the
So-
rectal bleeding.
I always tell them, thank your hemorrhoid. You wouldn't have come to us. But the bleeding was because of the hemorrhoid that we found. Like a collateral, the big guy is there,
I think it should be pointed out too with the Cologuard test that was mentioned. I mean, that's designed for a person of average risk, so
No
for your son, he would not be a candidate for
No,
the Cologuard test at all. That's not for someone with.
My husband had it done because there was none in his family, although his father had died of pancreatic cancer. His mother had a lot of skin cancer. He died of multiple myeloma. So, who knows?
And the genetic test, it looks at the hereditary aspect, so those kind of big genes that cause really high risks. We know in some families, we can see what we call more of a familial situation. So maybe we can't narrow it down to one single gene running through the family, but maybe it's a combination of multiple genes. So maybe many genes that are just adding up little by little, but also things like environment and lifestyle. So that's why in some families we might see that little bit of clustering of cancer. So even if you don't have one of these genes that causes that very high risk, there could still be a bit of an elevated risk there due to all of those other familial features, all those other things we share with our families. So just because you tested negative doesn't mean the whole family's completely out of the woods.
Absolutely.
And actually pancreatic cancer can be hereditary as well, so it might be something your son wants to look into regarding the
He
other
also
side
had
of the family.
pancreatitis, so.
Okay, and there are forms of hereditary pancreatitis that can increase pancreatic cancer risk. So you might want to talk to his doctor about having genetic testing to look at the other side of